good evening, and thank you for coming out on a rainy night like this. And let's see, I want to say how happy I was. I spoke to Lori Hamilton about a week ago, and she said, no, not the Food City in Bluntville, which is the one I'm familiar with, the one in Euclid. And I thought, no problem, I can do that. And then I'm so glad she said, you know, it's the new one across the street, because otherwise I would be over yonder thinking that you all had a very dry sense of humor. You know, it's like they closed down the whole store just for this joke. So, let's see. As she said, I work with ETSU right next to the hospital. We have a training program there for family medicine residents, and people often don't know what that is. These are people that have graduated from medical school, so they have their MD degree, but they need to get 3 more years of training to become family physicians, board-certified family physicians. So we have them working literally around the clock to practice patient care and to learn what they need to learn to become board-certified family physicians. And in family medicine, we take care of people all the way from newborns and really prior to birth when you're pregnant, all the way up to older care and beyond. So that's our specialty, is to try and have a lot of variety and just try and take care of the whole family at all ages. Okay. Let's see. And I apologize, I'm just getting over the crud, so if I have a coughing fit, that's the best I've felt in 2 weeks, so don't worry about that. So we're talking about food tonight a little bit, and you know, there's all kinds of food. There's fast food, there's good food, health food. Can't forget Southern food or soul food. But we're going to look at it a little bit differently tonight. From a medical standpoint, they tell us food is made up of 3 basic groups. There's carbohydrates, proteins, and fats. And one thing I've noticed as I've gone along is some of the fun gets pulled out of this. They now say that carbohydrates, you have to be careful. Simple carbohydrates, it can push you towards diabetes. They say, some people say Americans eat too many proteins and that we're eating more protein than we need to. A lot of people say we shouldn't eat fats. So it kind of takes the fun out of it. Like, those are all the 3 possibilities, and that doesn't leave very much left. So I always point out 1965, that's approximately the last year when food was good for you. Back then people say, oh, here, food, you know, it's good, right? And ever since then, this is bad for you, that's bad for you. I remember the astronauts, right? Their breakfast before going to space was always steak and eggs. You know, that's all American. And now we'd say, no way, that's terrible. So, yeah, exactly. So things have changed. Let's see. Okay, so we're talking about cholesterol tonight. And cholesterol is somewhat of a bad word, but we need cholesterol. We need it for our skin. We need it for actually all the cells in our body have some cholesterol in there to help hold the cell wall together. It's used as a precursor to make chemicals we call hormones that circulate through the body, and it's also used for formation of vitamin D. They have bile acids on there. It's used for that too, but you could probably get by without bile acids. But all these others are essential for you. So we need some cholesterol. It's just trying to have the right amount. Okay, the liver actually produces most of the cholesterol in our body. 20% comes from our food. The rest is made by the liver. And let's talk about that a little bit. There's different types. There's the HDL, that's high density lipids, and those are actually good for you. The more of that you have, the better off your risks are. There's LDL cholesterol, and most people know that's what we call the bad cholesterol. The more of that you have, the more risk you have of having heart disease. Triglycerides are another component of cholesterol, and we don't know for certain that that's a separate risk factor, but certainly if the triglycerides are high, we worry about things. If they're a little bit high, we sometimes worry whether you might be moving towards diabetes. If they're very high, it can actually cause problems with pancreatitis. So sometimes if it's real high, just the triglycerides alone will treat. And if you go to a screening like Gloria was talking about, often what we'll get is a total cholesterol. It's the whole mixture together. And the advantage of that is you can get a total cholesterol when you're not fasting. So if you've had lunch and you go by a screening place, we can check your total cholesterol and get an accurate number. To measure the LDL, which is what we often want to know about, you have to be fasting for 8 to 12 hours. And that's sort of a pain in the neck for people. So, okay. And the reason, again, we worry about all this is cholesterol leads to or increases our risk of having deposits in our arteries, especially the coronary arteries. And just to review, the heart is a muscle, right? It's an important muscle that pumps the blood around, but it's a muscle, and like all the muscles, it needs blood supply. And so the heart has 3 major arteries that supply blood to it. And if you get plaques in there, it can limit the amount of blood flow to that muscle. And if they rupture, they can actually cut off the blood supply. And that's the problem that we have with our heart is if you cut off the blood supply by a ruptured plaque, then that little part of the heart muscle dies. That's called a heart attack. And so what we're always trying to do is prevent that, to move your risk away from that happening. And here's again why cholesterol is an important topic. Heart disease, cholesterol is related to heart disease and also to stroke, risk of stroke. Combine those two together, and that is responsible for about 40% of all deaths. So it's a big common problem that affects a lot of people across the country. So it's something we want to spend effort and time on. Okay. In terms of our goals, we'd like our total cholesterol to be less than 200. We consider 200 to 240 to be borderline and above 240 to be high and in need of some fixing. Now, if you're one of my residents, I don't want to talk to you about total cholesterol. I want to talk about the bad cholesterol, the LDL. That's where we have the most accurate guidelines as far as where it should be. And if you have basically no risk factors, if you're completely healthy and have a healthy history, it should be below 160. If you have risk factors like hypertension or family history or a smoker, then we feel it should be below 130. And if you have a prior history of heart problems or if you have diabetes, then our goal is to have that LDL below 100. And actually, for known heart disease, there is some thought nowadays that maybe pushing that LDL down to 70 is an advantage. So we really focus on what the LDL is, and we really try and push that down. Okay. Again, just reviewing, LDL is a risk factor that correlates very closely with heart disease, and we know that if you lower the LDL, you reduce the risk factor, the risk. If you raise the HDL, you again improve a person's risk. Let's see. Okay. Here's a topic I like to talk about. Airplanes. Some people say, well, I used to be an engineer before I was a doctor. I used to work in the aerospace industry. So sometimes a topic comes up as, what's more complicated? An airplane, like the 747 is pretty complicated, or the human body? And I've sort of been in both fields. And here's the deal. In an airplane, you can, if you have enough time and patience, you can take a wire and trace it down and figure out where that one wire goes eventually. So even though you've got a lot of spaghetti and a lot of complexity, eventually you can figure out, well, this wire works the landing light. And that's what it does today, and that's what it does tomorrow. So there's at least something in an airplane where you can pin down, this does that. In the human body, over the past couple hundred years, people have tracked down a lot of the wires and tubes, and that's been helpful. So we know some things as far as cause and effect in the human body, but there's a bugaboo. In addition to all those tubes and wires in the human body, there's a bunch of organs that release chemicals, right? We call endocrine organs. They release hormones that affect different parts of the body, and they affect different parts of the body all over the place. You know, these chemicals get in there and they mix around, and they affect tissues here and there, and they interact with each other. And not only the endocrine system, but the immune system releases its own set of chemicals, interleukins and histamines, and they have effects on parts of the body, and that causes other effects and other parts to release chemicals. Even the blood vessels we know now release nitrous oxide. And there's a lot of studies like, well, they release nitrous oxide, what does it do? And how do they know when to release it? So all this stuff makes studying the human body very, very complicated. And I've learned from my kids, you hit this just wall of complexity and you just say to yourself, this is so unfair. I mean, so what do you do? And basically you've got two choices. You can either wait about 200 years till they sort this all out, or some other scientists that are impatient say, we have another approach. And their approach was Framingham, Massachusetts. And what they did is they said, look, we might not be able to figure out how all the little pieces work together, but if we look at a bunch of people as a group over time, we can figure out some cause and effect. So what they did is, starting in 1948, they studied the town of Framingham, Massachusetts. Initially 5,000 people, then even a whole bunch more. And they've been doing that for 60 years now. And they found out a lot of stuff. Again, they don't have a lot of details about why. That's sort of the basic scientists that look at all the chemicals and stuff. But by looking at this huge group of people and learning about what they do and how they do it and how their health is affected, we've been able to learn a lot of stuff. And in the 60s, some of the first stuff was that cigarette smoking is bad for you, increases your risk of heart disease. So you need to study a group, and that's what they did. They studied this large group, and they learned a lot of things. They didn't learn why the smoking is bad for you, but they learned smoking was bad for your heart. They also learned that cholesterol is bad. The higher that is, the more you have a risk of heart disease. And also that blood pressure, high blood pressure is bad. Exercise is good. Let's see what else. In the 70s, they learned that blood pressure increases risk of stroke. And in the 80s, they learned that HDL is good for you. The higher that is, the better. There is one problem with this. If you learn this, what you learn is statistical stuff. So you notice I say risk of heart disease. So what we can say is smoking increases your risk, having a low LDL decreases your risk. And that's helpful, but sometimes that's frustrating to people. They go to the doctor and he says, well, if you do this, you can reduce your risk by 10%. Well, I don't want to know that. I want to know, if I eat that steak, will I get sick or will I not? If I'm not going to get sick, I want to eat it. But knowing that it's going to reduce my risk 10% isn't quite as satisfying. So that's always a little bit frustrating. And doctors feel the same way. We get the data from the studies and the clinicians like, well, what do I do with this? What's the 5% risk mean? What's the 10% risk mean? But still, Framingham, because there's so many people there and we've studied so long, they actually have published a database where you can plug in information and get your approximate 10-year risk of having a heart disease, heart attack. And if you look at it overall, for Americans, if you start at age 40, men have a 50% chance sometime in their lifetime of having heart disease, women a 1/3 chance. And that's again why this is such an important topic. It affects a lot of people. It affects almost a majority of men and a large minority of women. So here are the risk factors that we pulled out of Framingham. The first one is actually the biggest risk factor, but it's hard to do much about. The older you are, the higher risk of having a heart problem. Cholesterol is a risk factor, and if that's high, it increases your risk. I started trying to put numbers on this, but it gets kind of complicated, so I just thought I'd leave it with cholesterol is, if it's high, it increases your risk. By about the same amount, uncontrolled blood pressure similarly increases your risk. Diabetes by itself, again, increases your risk. And if you wanted to put a number on it, each of these by themselves would add about 10 years to your life. In other words, if you're 40 but you had high cholesterol, you'd have the risk of a 50-year-old. If you're 40 and you have high blood pressure, again, you'd be about the risk of a 50-year-old for heart disease. And they add up. So if you have high cholesterol, high blood pressure, that's bad. If you throw diabetes on, that's, again, more risk. And then there's smoking, again, by a similar amount, would increase your risk. Let's see. Okay, so for the next couple slides, I'm just going to throw out a bunch of stuff we've learned from different studies. So not a great take-home message, but let me just go through a few of these things. Heredity and diet have significant influence on your cholesterol levels. So if you have good grandparents, you may have good cholesterol. The problem is that's hard to change. But also your diet will affect your cholesterol, and that is something you can change. Diets high in saturated fats and cholesterol tend to raise LDL levels. And saturated fats tend to come from animal products, right? So meat and dairy. And different meats have different amounts, and we'll get to that in a little bit. Let's see. modifying the fat in our food. If you replace the animal fats with vegetable-derived fats, that will tend to reduce your LDL, reduce your bad cholesterol. So that's a good thing to do. Whether plant fats come in monosaturated and polyunsaturated, there's not a study that says one is better than the other. And this one always disappoints me. I like to eat pasta and breads and stuff, so I like carbohydrates, right? It said if I get rid of my fats and just eat carbohydrates, there's no benefit to that they can show. And the same slide, again, there's no firm evidence that getting all the fat out of your diet is beneficial. So replacing the fats with more animal-based fats is good. Getting away from the saturated fats is good, but you don't need to throw it all out. Okay. And here's another issue again with studies, but as a physician, we go to the U.S. Preventive Services Task Force for a lot of recommendations. And again, they're very specific about the recommendations. Here they say, if I talk to you about diet and exercise, that's beneficial if I intensively, specifically speak to you about it. They don't know if you did it because, again, in a study, it's hard to go and see if people are actually doing the exercise. But they were able to measure whether doctors talk to people about it. When doctors talk to their patients about it, it was beneficial, presumably because they actually did exercise and modify their diet. But all they can say is, by talking to you about it, over time is helpful. Okay. And even there's the thing about oatmeal, as someone mentioned, right? So there's studies. Oatmeal is beneficial in lowering your LDL and your risk factors. Okay. Talked a lot about stuff. Okay, so to improve your cholesterol profile and therefore improve your risk, 3 things to work on would be diet, exercise, and getting rid of smoking if you're a smoker. And let me just talk a little bit more about diet and go on from there. Again, switching to a vegetarian diet strictly with a lot of soy products and nut products was able to lower LDL, your bad cholesterol, as much as going on a statin medicine. Typically, what we hope to do with a patient is to give them the medicine, if their LDL is too high, is to give them the medicine to lower it and have them do a diet to lower it and hopefully get the benefit of both. We always worry that we're giving out the medicine, the patient's going to rely just on the medicine and not adjust their diet. So that's, but working them together is certainly beneficial. So again, I didn't want to make this an all-night lecture, but in summary, reducing your meat consumption, adding fish to your diet, eating fruits and vegetables, all those things are beneficial. If you read this literature, they always like nuts. The fats in nuts are beneficial and tend to reduce your risk. However, in absolute terms, nuts do have a lot of fats in them. So it's one thing if you say, I'm not going to have the steak, I'm going to have a bowl of nuts. That's good. If you're going to have the steak and have the nuts, that's not so good because then you're getting both. So trying to point out the subtlety there is important. Yeah. And perhaps one of the take-home messages is to try and balance out the diet. Have some meat, but have your vegetables and your nuts and fruits in there as well. Foods that are known to be good for lowering cholesterol: oats, barleys, bean, nuts again, vegetable oils as a replacement for animal oils, and so forth. And I don't know if a few weeks ago at the hospital, Dr. Hayner gave a lecture talking about the China study. There they looked at the population in China. It's a big group, and this is years ago before all the modernization. Back then, people kind of stayed in their local towns and villages. They said, you know, some places in China have lower cancer rates, lower heart disease rates. Other places are higher. What's the difference? Like, they're all Chinese, right? So they looked at, and the diet was very different from one place to the other. And again, the take-home message there is moving away from animal fats towards plant-derived nutrients diet is a good thing. And let's see. Okay, and again, I don't want to belabor this in great detail, but moving away from things like butter, egg yolks, high-fat foods like sausages, and ice cream, and so forth. And again, if you're looking at meats, you want to move away from the red meats and think about things that are leaner. And down here you can see like pork, which again we're having the demo tonight. Things that are good, again, starting today with oat bran, vegetables, beans, berries, and nuts. Lean meats like chicken, turkey, lean ham, fish, soy products are all good. Okay. In terms of exercise, we've learned that exercise increases HDL. HDL is the good cholesterol, and that's been a frustration for the scientists and physicians. It's been hard to find a medicine that effectively pushes the HDL up, but exercise does, and exercise also will lower your LDL cholesterol. And when we say exercise, what they recommend nowadays, the American Diabetic Association, CDC, is 150 minutes a week, which is a lot. That's like half an hour, 5 days a week. At least on the plus side, they say moderate intensity is enough. So on a scale from 1 to 10, 5 is good enough. They talk about if you're, doing an exercise, it should be comfortable enough where you can talk, have a conversation. So depending whether that's fast walking or slow jogging, that depends on the individual and how much they've been training and stuff. But it doesn't have to be out of breath, sweating profusely. Just moving enough where you're just to the point where conversation is still comfortable, but not beyond. And then smoking cessation. Again, if you're a smoker, getting rid of that or reducing that is definitely beneficial. And of course, you've noticed all those things are things that you do. I'm used to spending my day writing prescriptions, but these things we've talked about, diet, exercise, and getting rid of cigarettes, are all what we call lifestyle changes. And we found that those things are most successful when you pick something and you manage it. The old model was the physician, where's my pen? The physician picks up their pen and says, you need to do this. Mm-hmm. And you really need to do this. But that actually has been shown not to help. What helps is you let the patient decide what they want to work on, let them set their goals, and when they're ready to do the change, encourage them to go ahead with that. One thing I've read about is an important thing in this lifestyle modification, is to pick realistic goals, something that you're pretty sure you can achieve. Start with something small enough that you say, pretty sure I can get there, and then build on that. You may want to run a marathon, but you need to start with saying, I'm going to go around the block twice tomorrow. Maybe next week I'll shoot for 4 times around the block. And by doing that, you can pick your goals and adjust them, and that's shown to be the most helpful. And that's basically all I've got. So that's my next slide. There was the boat going off. And then we move on to the chef, Larry, in the next room there. Any questions, comments, questions? Yes? I was going to type his name in there. I thought, well, you might not appreciate that. Go ahead.
How about fish oil?
Oh, Lord, yeah.
We heard that last week.
I have a brand new bottle of fish oil in my refrigerator. Okay, so what we've seen is that, like I said, if you replace your steak with other oils, that's beneficial. So people who live in Scandinavia and eat a lot of fish in their diet, they do well. Eskimos, they eat a huge amount of fat in their diet, but it's the omega-3 fish oils, they do well. We thought that by taking a supplement on the side of fish oil, that would lower your cholesterol and reduce your risk. But the study has shown that eating whatever diet you have and throwing in some fish oil on the side doesn't help. Doesn't help your heart disease risk. My wife is still convinced that it's supposed to be beneficial for your brain function and stuff, and it's like, so we give our kids fish oil. But as far as my fish oil for lowering my risk, if I take it as a supplement, that it's been shown that doesn't help.
Well, they brought my triglyceride stack.
Mm-hmm. And that may be a good thing. But as far as in the big study, yeah, didn't help. Okay, yes?
Flaxseed. What do you think of flaxseed?
Well, I mean, flaxseed was another type of omega-3, similar to fish oil, and the thinking was the same thing. And if you didn't care for fish oil, flaxseed was another way to get omega-3s. Again, we don't know for sure, but the study was, at least with fish oil, similar thing. Just throwing it on as a supplement didn't help heart disease risk. Now, it might help with cognition or not, but it didn't. Yeah. Right. Yeah, well, I've been taking fish oil for a couple of years, but again, the study now says that, at least for my heart, that's not going to be beneficial. So, what's that? Yeah, yeah, and that'll be a good dose. Yeah, and again, so what it says now is like, if you're going to have the fish oil instead of some other oil in your diet as a replacement, that'll help. But as far as just eating whatever you are and then just throwing that on top, the study showed it no benefit. Yeah.
Are you supposed to keep the fish oil in the refrigerator?
Oh, I don't know. So my wife puts it. So. Oh, yeah, I don't.
For the burping effect.
Mm-hmm.
Yeah, in the freezer, is what I heard, if you
Put it
freeze
back
it, keep it in the
together.
refrigerator and
It's
freezer.
the other fish oil.
I'm sorry?
That mega red.
Mega red.
That's something we
Yeah, I'm not convinced that one brand is that much better. I spoke to someone who worked at the VA, and they were like, "Oh, I forget Nature's brand or Nature something," and yeah, my wife found some expensive brand that she gets someplace that's has a strawberry flavor to it. So when you do burp, it's more of a it's good, but she got that for the kids. I used it for a while, but then it's so expensive. It was like, okay, I'll just go with regular stuff. Yeah. Okay.
What about the Creole oil?
Sorry.
Creole, K-R-I-L-L, Creole.
That's
Ooh.
the mega red.
That's
the
Okay.
mega red. And it's
Okay.
much more expensive than fish
Okay.
oil.
Yeah.
But it's supposed to be better.
Yeah.
so.
Yeah. Yeah. Again, all I know is that from the one study, couldn't demonstrate a benefit for your heart.
What about the red yeast rice? Taking that?
Oh, to reduce your cholesterol?
Yes. My doctor told me that if I went off of the statin, that was a good thing to take. So I'm just wondering.
I can't speak with great authority on that. I have heard that lowers LDL cholesterol. But you also mentioned the word statin.
Yeah.
So there's this special drugs they call statins, right? They're Pravachol, Crestor, Lipitor, Zocor, all the ors. Right. Statins have magical qualities, mystical qualities, if you ask doctors, right? If statins will lower your LDL cholesterol. Other things can do that. So like they looked at this one group of people, they had stomach bypass surgery. So they were eating less, their LDL came down. They had a lower risk of heart disease, but the people on statins had an even lower risk. Their risk of heart disease went down more than you could explain just by the LDL lowering. And they said, why is that? And the God's honest truth is, we don't know. All the physicians think it must stabilize that plaque. Remember we saw the plaque? And we say, surely it's because it has some ability to stabilize the plaque so it's less likely to rupture and cause a heart attack. But we don't know that for sure. What we know is the statin somehow reduces your risk of a heart attack more than you would expect just based on the LDL lowering. What that extra benefit is from, we're not sure, but it sounds better to say it must be stabilizing the plaque. If you say, I just don't know, then people look at you like, huh? But we really don't know.